Hi viewers, now we'll see Geriatric Assessment Part 2 Objective Assessment. I am Dr. Kalaiselvi Xavier, Professor, Tribhuvan College of Nursing. At the end of the class, the students will be able to explain how to do a physical examination of the geriatric assessment and also to recognize the common problems related to the geriatric assessment. As introduction, geriatric assessment is a multidimensional, multidisciplinary assessment. It should be designed to evaluate on older persons' functional ability, physical health, cognition and mental health and socio-environmental circumstances. It also to be initiated when the physician identifies the potential problem. Specific elements of physical health that are evaluated include nutrition, vision, hearing, fecal and urinary incontinence and balance. Now we'll see general consideration for old age. Always we have to limit the time for patients is in the supine position as this may cause back pain for persons with osteoarthritis or kyphoscoliosis or shortness of breath for those with cardiac pulmonary disease. And also having several pillows on hand for these patients will be greatly appreciated. And multiple sessions may be required for a complete physical exam due to patient fatigue. While they are important, the rectal and pelvic exams may be referred to a later session if not urgently required. The terminology is gait. Gait means the way of persons walk. The posture. Posture is the position in which the person hold their body while standing, sitting or lying down. Good posture involves training the body to stand, walk, sit and lie so as to place the least strain on muscles and ligaments while persons are moving or performing weight bearing activities. Reflexes. A reflex is an involuntary and nearly instantaneous movement in response to a stimulus. The reflex is an automatic response to a stimulus that does not receive a or need conscious thought as it occurs though a reflex arc. Reflex arcs act on an impulse before that impulse reaches the brain. What is sensation? Sensation is the ability to feel things physically, especially through the person's sense of touch. What is behavior? Behavior is a specialized term used in fields such as psychology, social science and education. Intellectual describes something related to or using the mind or intellect. What is ecchymosis? Ecchymosis is the discoloration of the skin caused by the movement of blood from ruptured blood vessels into the top layer of the skin. Now we will see the steps of physical examinations. What is the purpose of routine physical examination? We have to observe the patient and their movements. Example, walking into the examination room, sitting in or raising from the chair, getting on and off an examination table, taking off or putting on socks and shoes, and can provide valuable information about their functions and the personal hygiene, state of dress, cleanliness, smell may provide information about mental status and the ability to care for themselves. What is the functions of the routine physical examination? If patients become fatigued, the physical examination may need to be stopped and continued at another visit. The elderly patients may require additional time to undress and transfer to the examination table. They should not be rushed. The examination table should be adjusted to a height that patients can easily access. A footstool facilities mounting. Trial patients must not be left alone on the table. Portions of the examination may be more comfortable if patients sit in the chair. And also the clinicians should describe the general appearance of the patient: comfortable, restless, undernourished, inattentive, pale, dyspnea, cyanotic. If they are examined at bedside, use of protective padding or a protective mattress, side rails It may be partial or full, restraints if necessary, urinary catheter if the patient is incontinence at bedridden. Then adult diaper should be noted. Vital signs: weight should be recorded in each visit. During measurement, balance problem may be grab bars placed in ear or on the scale. Height is recorded annually to check for height loss due to osteoporosis. Temperature is recorded. Hypothermia can be missed if the thermometer cannot measure temperature more than few degrees lower than normal. Absence of fever does not exclude infection. Pulses and BP are checked in both arms. Pulse is taken for 30 seconds and any irregular to be noted. Because many factors can alter the BP, BP is measured several times after patients have rested more than 5 minutes. Now we'll see the assessment. Here we'll see the head to foot geriatric assessment. The components integumentary system assessing the skin. Here the normal findings: wrinkled skin results from loss of elasticity and turgor. Here with the age the skin gradually thins and loses density, making it more susceptible to bruising and tears. Here we'll see the abnormal findings. Inspect the skin for lesions and moles. When examining moles, look for irregular shapes. Ask the patient if any moles have gotten bigger or changed color. Positive findings indicate the need for further evaluation by a primary care provider or dermatologist. Keep in mind that excessive sun exposure exacerbates aging related changes and may lead to skin cancers such as melanoma. Pressure ulcers are most common on the sacrum, heels and trochanters. Then assessing the hair, the normal assessment: an aging related decline in melanin protection makes the hair less vibrant in color, leading to graying, and also the hair thins. Many older adults lose their hair altogether. What are the findings? Dermal vascular beds diminish with age as well, altering hair distribution patterns, and some of the men are genetically predisposed to baldness and may experience hair loss at younger ages. Now we'll see the assessing the nails. Regardless of the patient's age, nail surfaces normally are flat or slightly curved. Note their color and also length and the cleanliness. Here the abnormalities: for instance, clumping may indicate a cardiac or pulmonary disorder. Pitting and transverse grooves may signify peripheral vascular disease. Arterial insufficiency or diabetes. Brittleness may stem from decreased vascular supply, whereas yellow or brown nails may signal a fungal infection. And now see the head, neck and face. The essential purpose of the skull is to protect the brain and other sensory organs for direct injury. Note the general size and shape of the patient's head. Are they appropriate to body size? The abnormalities: the head rests on the 7 flexible vertebrae of the neck. The neck gives the head maximum mobility. Limited range of motion, as from arthritis or muscle weakness, can cause pain and discomfort in older adults. As we evaluate neck ROM, stay alert for reports of pain or dizziness or jerky movements abnormalities. These may be clues to health problems such as fracture, vertebra, Parkinson's disease, a transient ischemic attack or stroke. What is assessing the face? How to assess? Each individual has unique facial features, but environmental, racial, genetic, emotional, and nutritional factors greatly affect the facial appearance and functioning. And here the findings to be noted: whether the patient's eyebrows, nose, and mouth are centered and symmetrical. It is asymmetrical features such as stroke, look for appropriateness of affect and behavior, check facial skin for dryness, sagging, looseness, and wrinkling, which result from aging related decreases in elasticity, subcutaneous fat, and moisture. In the vision and hearing assessment, vision can be deteriorate with age. Older adults should have 20 divided by 40 vision or better. Such conditions as changing eye shape, we have to assess whether presbyopia and cataract and glaucoma typically worsen with age. Because of the structural changes in the eye, older adults may be more sensitive to glare. As a result, shiny surfaces may increase the risk of falls and result in injury. We have to encourage adults to get annual eye exams. Hearing loss is common in older adults and usually affects both ears. In general, older adults have more trouble hearing high frequency sounds such as consonants, especially P, S, and T, than low frequency sounds such as vowels. We have to refer the patient with hearing difficulty to an audiologist. Regard to musculoskeletal system and functional status, the normal findings are maintaining independent functioning as long as possible improves quality of life, a fundamental principles of geriatric nursing, and to be assist the patient's ability to perform activities of daily living, that is ADLS, including bathing, dressing, toileting, transfer, continence, and feeding, and also assess for complex functioning skills such, such as those needed to perform instrumental ADLS. And we should see the abnormalities to investigate for the abnormalities suggested by the health history data such as loss of balance, gait disorders, postural abnormalities, or inability to transfer from a chair to a standing position. If the patient is weak with poor coordinations, patient may need to allot additional time for the functional examination. To see the continuation of musculoskeletal system and functional status, here the normal activities that enable a individual live independently. We have to assess whether their ability to use the telephone, travel, shop, prepare meals, do household activities, take medication appropriately, and managing the money. And to see the abnormalities, to evaluate muscle groups for atrophy, tremors, and involuntary movements. ROMS tests in older adults are similar to those used in other age groups. However, we have to assess inflamed joints may limit ROM in older adults. Inspect joints of the hands, wrists, knees, hips, and shoulders or areas more prone to arthritis. Note warmth, swelling, tenderness, crepitus, and deformity. Evaluating the patient's fall risk. When assessing the patient's fall risk, use a valid and reliable tool such as the Mohs fall scale or Tenet gait and balance assessment, with CMS no longer reimbursing for care related to patient's falls. Fall risk assessment and appropriate intervention are especially important. Here the abnormality conditions to be noted for osteoporosis can increase an older adult's risk of falling. Falls may lead to injuries with devastating effects including decreased function, fractures, and sometimes even death. Here to be assessed neurological system, neurologic examination for elderly adults is similar to that for any adult. However, non-neurologic disorders that are common among elderly people may complicate this examination. For example, visual and hearing deficits may impede evaluation of the cranial nerves and periarthritis. Example, inflammation of tissues surrounding the joint in certain joints, especially shoulders and hips, may interfere with the evaluation of motor function. Signs detected during the examination must be considered in light of patient's age, history, and other findings. Systematic findings unaccompanied by functional loss and other neurological symptoms and signs may be noted in early patients. Clinician must decide whether these findings justify a detailed evaluation to check for the neurological lesion. Patients should be re-evaluated periodically for functional changes, asymmetry, and new symptoms. Here, the cranial nerves evaluation may be complex. Elderly people often have small pupils. Their pupillary light reflex may be sluggish, and their pupillary mitotic response to near vision may be diminished. Upward gaze and to a lesser extent downward gaze are slightly limited. And always eye movements when tracking on examiner finger during evaluation of the visual field may appear jerky and irregular. Bell phenomena, that is the reflex upward movement of the eyes during closure, is sometimes absent. These changes occur normally with age. And also in many elderly people, sense of smell is diminished because they have fever, olfactory neurons, have had numerous upper respiratory infection or have chronic rhinitis. However, asymmetric loss of smell in one nostril is abnormal. Taste may be altered because the sense of smell is diminished or because patients take drugs that decrease salivation. Here, visual and hearing deficits may result from abnormalities in the eyes and ears rather than in nerve pathways. Motor functions. Patients can be evaluated for tremor during handshaking and other simple activities. If tremor is detected, amplitude, rhythm, distribution, frequency, and time of occurrence are noted. Then to be assessed muscle strength, elderly people, particularly those who do not do resistance training regularly, may appear weak during routine resting. For example, during the physical examination, the clinician may especially straighten a patient's elbow despite the patient's effort to sustain a contraction. If weakness is symmetric, does not bother the patients, and has not changed the patient's function and activity level, it is likely to be clinically insignificant. Increased muscle tone or measured by flexing and extending the elbow or knee is normal finding in elderly people. However, jerky movements during examination and cagwheel rigidity are abnormal. Sarcopenia, what is sarcopenia means? It is a decrease in muscle mass. Is a common age-related findings. It is a insignificant unless accompanied by a decline or change in function. Example, the patient can no longer rise from a chair without using chair arms. Sarcopenia affects the hand muscles. Example, interosseous and thenar muscles is particular. Weak extensor muscles of the wrist, fingers, and thumb are common among patients who use wheelchairs because compression of the upper arm against the armrest injures the radial nerve. Arm function can be tested by having patients pick up on eating utensils or touch the back of their head with both hands. Then we'll see the coordination. Motor reaction time and also motor coordination are tested. Reaction time often increases with age, partially because conduction of signals along peripheral nerves slow. Coordination decreases because of changes in central mechanism, but this decrease is usually subtle and does not impair function. And gait and posture. All components of the gait should be assessed. They include initiation of walking, step length, height, symmetry, continuity and cadence, velocity, stride width and walking posture. Sensation, musculoskeletal and motor control and attention, which are necessary for independent coordinated walking, must also be considered. In people with a gait velocity of less than 1 m per second, mortality risk is significantly increased. Aging has little effect on walking, cadence, or posture. Typically, the elderly walk upright unless a disorder is present. And some of the causes of the gait dysfunction. Overall postural control is evaluated using ramp-back test. Example, patients stand with the feet together and eyes closed. Safety is paramount and the clinician doing the ramp-back test must be in position to prevent the patients from falling. With aging, postural control is often impaired and postural sway. Movement in the anterior posterior plane when patients remain stationary and upright may be increased. Reflexes, the deep tendon reflexes are checked. Aging usually has little effect on them. However, eliciting the Achilles tendon reflex may require special techniques. Example, testing while patients kneel with their feet over the edge of the bed and with their hands clasped. A diminished or absent reflex present in nearly half of elderly patients may be normal. It occurs because tendon elasticity decreases and nerve conduction in the tendon long reflex arc slows. Asymmetric Achilles tendon reflex usually indicate a disorder. And to be seen cortical release reflex, that is a pathologic reflexes which include snort, sucking and palmomental reflexes commonly occur in elderly patient without detectable brain disorders. Example, dementia. Babinski reflex extensor plantar response in elderly patient is abnormal. It indicates an upper motor neuron lesion, often cervical spondylosis with partial cord compression. Then we'll see in a sensation. Evaluation of the sensation includes touch using a skin prick test, cortical sensory function, temperature test, proprioception, joint position sense, and vibration sense testing. Aging has limited effects on sensation. Many elderly patients report numbness, especially in the feet. It may result from a decrease in size of fibers in the peripheral nerves, particularly the large fibers. The patient with numbness should be checked for peripheral neuropathies. In many patients, no cause of numbness can be identified. Here, many elderly people lose their vibratory sensation below the knees. It is lost because of the small vessels in the posterior column of the spinal cord change. It should be noted, however, proprioception, which is thought to use a similar pathway, is unaffected. And also, always we have to remember for the elderly persons, this is a problem, grandma or less of a person because of age. Be comfortable to have a distress recognized, physically and emotionally comfortable. Be remembered, always patience. Health problems or distress internally to be understand and know the treatment and care in plan and length of the treatment, and also to be understand the self determinations about what activities to be noted. As conclusion, the older population is quite heterogeneous. Although patients may have similar ages of comorbidities, they often vary widely in their functional abilities. To provide outstanding care to geriatric patients, nurse must provide individualized patient-centered care despite the time constraints imposed in the modern world. Using the screening and assessment tool outlined in this review, healthcare providers can perform efficient personalized geriatric evaluation of older adults tailored to each patient's need. This comprehensive assessment helps us maximize older patients' function and thus quality of life and ability to age in place. These are all the references referred. Thank you for patient listening.